metastasis. It is really the defining feature of cancer lethality.
It's the absolute end game.
Right. When a primary tumor breaks free and, you know, sets up shop elsewhere in the body, that systemic spread is responsible for the overwhelming majority of morbidity and mortality for cancer patients. So if you want to understand cancer, you really have to understand metastasis.
Absolutely. And that's our mission for this deep dive. We've taken a stack of sources, primarily a comprehensive medical text focused on cancer metastasis through the lymphovascular system.
And distilled it down.
And distilled it down to its most crucial scientific nuggets. This isn't just a basic overview. This is a structured, detailed breakdown. We're covering the molecular, the cellular, diagnostic, therapeutic aspects, all of it.
And it's really designed for learners, right? For the medical student, the young professional.
Or anyone who needs to be thoroughly informed on this subject.
Our goal is to serve as your expert guides, cutting through the density and ensuring you understand not just what happens, but why it matters clinically. Okay, let's unpack this and start at the foundation. What transforms a normal cell into a malignant entity that's capable of invading and spreading?
We have to begin with the molecular foundations. At its heart, cancer is a disease of the genome.
Of the genes.
It's driven by the accumulation of mutations, somatic or inherited, layered with epigenetic changes. And it all ultimately creates an autonomous organ that just ignores the body's normal regulatory signals.
And the roadmap for this transformation, which has become really the guiding principle for oncology research, is defined by Hanahan and Weinberg's hallmarks of cancer.
Right. What started as 6 essential properties has expanded over the years.
To include things like genome instability, avoiding immune destruction.
And critically for our discussion today, tissue invasion and metastasis.
So to survive the journey of becoming a tumor, the cell has to master these survival skills. One of the most important is resisting programmed cell death, or apoptosis.
Non-negotiable. The body has multiple firewalls designed to kill a rogue cell.
And the cancer cell has to neutralize all of them.
All of them.
So it's not enough for it to block just one defense mechanism. It has to block 3 major circuits.
Precisely. Let's break those down. First, you have the extrinsic pathway.
Triggered from the outside.
Exactly. Think of it as a kill order delivered by a death receptor, like the Fas ligand binding to the Fas receptor. Second, the intrinsic pathway, which is governed by the mitochondria.
An inside job.
Right. Stresses cause the mitochondrial membrane to destabilize, activating these pro-apoptotic proteins BX and BAK. This leads to cytochrome C-CoD leaking into the cytoplasm, which then activates caspase-9. It's an internal cellular collapse.
That distinction is key for learners. Extrinsic is the external kill signal. Intrinsic is the internal pressure cooker blowing up. So where is the third circuit, the perform granzyme pathway, fit in?
That's the immune system's direct attack. It's mediated primarily by cytotoxic T cells.
Right.
They deliver perforin to puncture the cell membrane and then inject granzymes.
And the granzymes do the real damage.
They do. They either activate another caspase-10, or they just directly cleave the cell's DNA. It's essentially an execution. Evasion of these 3 systems grants the cell the critical survival advantage it needs to thrive.
And that survival is often accompanied by this aggressive level of genetic instability that just turbocharges tumor evolution. We're talking about massive changes like chromosomal aneuploidy.
The wholesale loss or gain of entire chromosomes or large chromosomal arms.
Yeah. So this aneuploidy is often associated with the loss of function in critical tumor suppressors like P53.
And what's fascinating here is how this instability generates intratumoral heterogeneity.
Meaning a single tumor hosts incredibly diverse populations of cancer cells.
Exactly. But these patterns aren't random. They are often tumor type specific.
Can you give us a specific example, something a pathologist or a researcher might actually look for?
Certainly. In testicular germ cell tumors, for instance, a characteristic signature is the gain of chromosome 12p. Conversely, in aggressive squamous carcinomas, whether of the esophagus, lung, or head and neck, you frequently see this coordinated gain of the long arm of chromosome 3, so 3q, and a loss of the short arm, 3p. These patterns are crucial. They dictate prognosis and even potential drug targets.
Most cancer is acquired, but we know maybe 5 to 10% is hereditary. We're talking about syndromes like Lympho-Mini linked to mutations in TP53, or Lynch syndrome tied to inherited defects in mismatch repair genes.
And the Lynch syndrome example offers one of the most counterintuitive insights into prognosis in all of oncology.
Oh, this is interesting.
Lynch-related colorectal cancer, even though it can look quite aggressive under the microscope, often has a better prognosis than sporadic colorectal cancer.
How does that work? Why does a genetic mutation that causes cancer in the first place lead to a better outcome once the cancer actually develops?
It's linked to its underlying genetics, specifically a state called high microsatellite instability, or MSI-high. This massive mutation load doesn't just damage the cell, it creates an avalanche of abnormal neoantigens.
So the immune system can see it better.
It sees these highly mutated cells as profoundly foreign. This promotes a really robust anti-tumor immune response. This intense inflammation and immune activity provide a clinical advantage and, importantly, make these tumors exquisitely sensitive to modern immunotherapy.
It really just demonstrates how much the molecular details dictate the clinical destiny.
It really does.
That sets the stage beautifully for the next phase. Once these highly mutated resistant cells have established a foothold, how do they actually break free? This is the metastatic cascade.
It's a tightly regulated sequential process. It involves 4 major phases.
4 steps.
First, the cell must shed its epithelial identity and undergo epithelial mesenchymal transition, or EMT, to acquire motility. Second, it infiltrates the vessels, that's intervasation, becoming a circulating cancer cell, a CTC.
Then it has to get out again.
Third, it travels to a distant site and exits the circulation, which is extravasation. And finally, the really hard part, it must successfully adapt and colonize the new distant organ.
What I find remarkable, and what the source material really stresses, is that this entire cascade is just incredibly inefficient. It's a high-risk, low-reward gamble for the cancer cell.
Extremely high risk. I mean, for every million cells that intravasate, maybe only a handful successfully complete the cascade and colonize. The vast majority are eliminated.
Just wiped out in the bloodstream.
Wiped out or eliminated by the immune system once they extravasate. This inefficiency is a major bottleneck that prevents widespread metastasis in every single cancer case.
And a crucial determinant of success or failure during this escape is the surrounding environment, the tumor microenvironment, or TME.
Right.
It's not just the cancer cells acting alone, it's a coordinated attack supported by the host's own cells. Let's talk about cancer-associated fibroblasts, or CCAFs.
CCAFs are, well, they're fundamentally fibroblasts that have been hijacked and reprogrammed by the tumor. Functionally, they're radically different from normal fibroblasts. Experimental data proves that CCAFs are profoundly protumorigenic. They actively direct tumor progression. They release factors that induce that mesenchymal-like phenotype. They're essentially paving the road for the cancer cell to move out.
Whereas a normal fibroblast would sort of hold it in place.
Usually, yeah. They help maintain structure and hinder invasion.
And if the tumor needs its own highway system, both blood and lymph, it relies entirely on a pivotal growth factor, VEGF.
Vascular endothelial growth factor. It's the orchestrator here. VEGF-A is the classic signal, primarily regulating angiogenesis, the growth of new blood vessels.
Which is why it's a drug target.
Exactly, why it's the target of drugs like bevacizumab. However, for lymphovascular spread, we have to look at VEGF-C and VEGF-D. They are the dominant drivers of lymphangiogenesis, providing that critical route for dissemination via the lymphatic network.
But dissemination isn't always through standard blood or lymph vessels. The sources mention these more esoteric migration routes, things like extravascular migratory metastasis, angiotropism.
Parasitic mimicry, yeah. These are slower, more persistent modes of dissemination, particularly noted in melanoma.
So what's the theory behind them?
The underlying hypothesis is that these mechanisms represent a reversion to embryonic forms of migration, a kind of cellular amnesia, where the cell travels along pre-existing structures, almost like neural crest cells migrating during fetal development.
Wow. So they're quiet, progressive.
And a major challenge for local control.
Now, for one of the scariest clinical challenges, tumor dormancy. Cells that successfully extravasate, but then just sit quietly, sometimes for decades, only to awaken and cause recurrence years after the primary tumor has been treated.
Tumor dormancy is a critical survival mechanism, and it's heavily regulated by the cell's interaction with the extracellular matrix, the ECM.
The surrounding scaffolding.
Right. And specific ECM components can act as a switch. For instance, high levels of collagen have been shown to induce the transition from dormancy to outright outgrowth.
And what keeps them dormant?
Components like fibronectin seem to facilitate the survival of cells in that quiet, quiescent state.
Okay, here's where it gets really interesting on a metabolic level, and this is crucial for treatment planning. Proliferating tumors are famous for the Warburg effect.
Relying almost entirely on rapid glucose consumption or glycolysis.
What happens when a cell goes dormant? Does it still burn sugar?
It flips the script entirely. This is a profound example of metabolic plasticity. When oncogenes like HER2, KRAS, MYELIC, or WENT are successfully inhibited by a targeted drug, the tumor cells immediately drop their glucose uptake.
And to survive.
To survive the subsequent quiescent state, when they are no longer rapidly dividing, they upregulate pathways that rely on fatty acid oxidation, or FAO.
So instead of burning sugar fast, they're slowly metabolizing fat. What's the clinical consequence of that switch to FAO?
The consequence is twofold and, well, devastating for therapy. First, the FAO pathway generates increased reactive oxygen species, which is paradoxically essential for the cell's survival during quiescence.
Okay, and second,
Second, because the cells are quiescent, not actively replicating their DNA standard cytotoxic chemotherapies, which target rapidly cycling cells, become completely ineffective. This metabolic difference is why we can successfully treat the primary proliferating tumor, but fail to eliminate the silent, dormant disease.
that is a critical takeaway for our learners. The metabolic state dictates therapeutic vulnerability. Transitioning now to detection. How do we track this complex, heterogeneous disease? We start with the pathologist's evaluation of the tissue.
Pathologists use a highly structured visual algorithm. First, they're looking at the low-power architecture to determine if the lesion is primary or secondary. Then they zoom into the high-power cellular and nuclear morphology.
They're like medical detectives.
Highly skilled ones, yeah. They're inferring the primary site of origin from sometimes subtle features within the metastasis itself.
What are some of those telltale histologic hallmarks they look for?
They are looking for context. For instance, metastatic colorectal carcinoma often displays these elongated hyperchromatic pencilate nuclei. They're sometimes stacked together, and they frequently show what we call grungy necrosis, where the dead cellular material looks dark, granular, and, well, dirty.
And that's different from, say, pancreatic cancer.
Very different. Pancreatic ductal adenocarcinoma often has neoplastic cells that present with clear cytoplasm. These patterns provide the initial powerful clue that guides the entire differential diagnosis before any molecular testing is even done.
Moving to minimally invasive methods, liquid biopsy analyzing, circulating tumor cells and circulating tumor DNA has been a diagnostic game changer.
It truly has. CTC analysis reveals important prognostic information. We now know that clustered CTCs have a survival advantage. They're protected from a type of cell death called anoikis, which is triggered by detachment from the ECM.
And when they cluster with other cells.
When these CTCs aggregate with neutrophils, forming these heteroaggregates, they are strongly associated with faster disease advancement and enhanced metastatic potential.
And ctDNA helps us track the molecular evolution of the disease.
Absolutely. ctDNA analysis is largely concordant with the tissue sample, and it's invaluable for real-time tracking of disease progression. We can detect resistance mechanisms like AR alterations in metastatic castration-resistant prostate cancer, or even use it for early detection like the ecipetine methylation test for colorectal cancer screening.
However, the sources note a key limitation regarding sampling location.
Yes, this is important. For primary brain lesions confined to the central nervous system, plasma ctDNA detection is often poor, sometimes only detecting about 20% of cases.
So what's the solution?
This highlights a critical principle. For lesions within the CNS, cerebrospinal fluid, or CSF, ctDNA analysis is far superior. It bypasses the blood-brain barrier issue and offers significantly higher sensitivity.
Let's quickly summarize the role of imaging in staging. We have CT, ultrasound, MRI, PET, all playing complementary roles.
For detecting distant metastases, MRI remains the most sensitive screening test, particularly for the brain. Classic brain mets usually appear dark on T1, bright on T2, and show avid, ring-like contrast enhancement.
But there are exceptions.
There are always exceptions, you must know. Melanoma metastases are famous for being T1 hyperintense bright on T1 due to the paramagnetic properties of melanin's free radical content.
And for skeletal lesions, what about the newer hybrid imaging modalities?
Hybrid imaging, specifically PT-MRI, combines the anatomical sensitivity of MRI with the molecular specificity of the PT tracer. This is being actively investigated for bone lesions.
And the results?
While some studies suggest slightly higher detection rates for small bone lesions compared to PT-CT, the overall clinical impact, it's still being carefully evaluated. We're waiting to see if that slight diagnostic edge translates into meaningful clinical benefit, especially given the cost and time.
That detailed mapping brings us to the ultimate step: modern therapeutic strategies. The lymphatic system, which we identified earlier via VEGF-CD, is clearly a major route. This makes the sentinel lymph node a prime target.
The lymphatic system acts as the first line of defense, but also as a highway. Sentinel lymph node biopsy, or SLNB, is crucial in malignancies like breast cancer and melanoma.
And a negative result is huge.
The clinical significance of a negative SLNB cannot be overstated. It is associated with significantly improved survival and a low distant metastasis rate, typically under 10%.
This feeds directly into the gateway hypothesis.
Exactly. The hypothesis posits that the sentinel lymph node isn't just a rest stop. It's the major gateway for cancer cells to access the systemic circulation. The idea is that once cancer cells reach the SLN, they may invade venous channels located within the node, bypassing the rest of the lymphatic chain and directly entering the bloodstream.
Let's pivot to the surgical management of skeletal metastases. When a patient presents with bone lesions, a multidisciplinary team has to weigh several critical questions before any operation.
The surgeon's checklist is rigorous. They have to ask, is tissue confirmation necessary? Is the metastasis isolated, making it amenable to a curative intent local therapy? What's the expected response to antiaplastic therapy?
And the practical side of things.
And perhaps most practically, what is the quality of the remaining bone stock? That last point dictates the entire reconstruction strategy.
Can you give an example?
Sure. Lesions in the proximal tibia often compromise the metaphyseal bone. This means you have to use a rigid plate and screw reconstruction because a standard intramedullary rod would just fail to get adequate fixation in that compromised bone.
I want to highlight one sophisticated regional therapy that shows how we can use local concentration to our advantage: hepatic arterial infusion, or HAI, chemotherapy.
HAI is a very precise tool. It involves delivering high concentrations of a drug directly to the liver via a surgically placed pump. This maximizes the local effect while minimizing systemic toxicity.
And it's used for liver metastases.
It's used effectively for colorectal liver metastasis, or CRLM, and intrahepatic cholangiocarcinoma. For CRLM, HAI dramatically improves hepatic progression. Free survival, meaning local control, is excellent. But the debate continues whether this translates into an overall survival benefit when paired with modern systemic therapy.
But for cholangiocarcinoma?
For intrahepatic cholangiocarcinoma, however, combining HAI with systemic therapy has shown improved overall survival.
To conclude our journey through therapy, let's quickly trace the evolution of systemic treatment.
We've come a very, very long way. We began with cytotoxic alkylating agents, developed initially after observing the effects of World War I mustard gas exposure. That slowly led us to the era of precision oncology.
So highly targeted agents.
Highly targeted agents that exploit known genetic weaknesses, like BRAF/MEK inhibitors for melanoma or various TKIs for ALK and EGFR mutations in lung cancer.
And the current frontier that has redefined prognosis for so many patients: immunotherapy.
The advent of immune checkpoint inhibitors, targeting pathways like PD-1, PD-L1, and CTLA-4 blockade, has delivered unprecedented durable responses in diverse tumor types. And there are constantly emerging pathways under investigation, like TIGIT, an immune checkpoint that inhibits T and NK cell activity.
So the field is just constantly adapting.
Constantly adapting to exploit the cancer cell's vulnerability.
So what does this all mean? This deep dive shows us that metastatic disease is not a haphazard event. It's a precise, multi-step process governed by profound genetic and metabolic plasticity, heavily reliant on the manipulation of the host's microenvironment.
Mm-hmm.
The current and future trend in oncology is decisively moving toward personalized multimodal care that relies entirely on these detailed molecular and cellular insights, whether they're gathered from high-resolution imaging, pathology, or liquid biopsy.
To solidify your understanding of one of the most counterintuitive concepts we discussed, let's leave you with a concept review question. It's based on that metabolic heterogeneity we talked about. If a targeted drug successfully suppresses a tumor's oncogenic signaling, what is the primary metabolic shift the surviving dormant cancer cells are likely to adopt? And why does this sudden change present such a profound challenge for standard chemotherapy? Think about the shift from glycolysis to fatty acid oxidation and why a non-dividing cell resists traditional chemo.
And building on that crucial concept of the gateway hypothesis, if the sentinel lymph node truly acts as the major physical and immunological gateway for systemic metastasis, and we know cancer cells actively modify the SLN into an immunosuppressive niche before colonization, how might future therapies move beyond current surgical removal?
An interesting question.
Could we utilize proactive prophylactic interventions at the SLN level? Could we intercept systemic disease entirely by neutralizing that niche? It's a provocative thought for future researchers focusing on intercepting cancer at its earliest, most vulnerable systemic stages.